Hey Dinks, another great episode here on the floor of the Chicago Midwinter 2026. We have an amazing guest with us, Sara Vasiliou, who's a registered dental hygienist here with the company Centrix. We are so excited to have you in the booth today.
Thank you for having me.
Great conversations happen in here. So first off, just talk to me a little bit about who you are. You have you're a dental hygienist. You're working with Centrix. Like, what's all that relationship, and what's your daily life like?
Well, I will tell you, I've been in dentistry for over 30 years, which I never thought I'd actually say that in my lifetime. But I have been working with dentistry since I was a teenager, working with amazing dentists.
That's awesome.
And I've been able to see the progression of dentistry over the years. During COVID, I actually had to stay home with my kids who were doing the hybrid learning, and I had a couple of friends that were, into Centrix. They had some connections, and they said, you should really check into this.
Oh, that's cool.
And so I did. My main goal was fluoride varnish because I'm a hygienist, so I have a lot of experience with that. And basically what happened was I started as a sales rep, and I basically have moved up to clinical education manager. So now I am really responsible for, pretty much training all of our new reps, but also doing a lot of lunch and learns so that we can make sure that the entire team is on board with prevention and restoration and all the things that are happening in dentistry. So it's been really exciting.
Yeah.
I do work from home, which is really nice. But a lot of the things that I do are via Zoom.
Very
this
nice.
day and age, everyone's doing things virtually.
Yep.
So coming to a show like this really does give us an opportunity to showcase the products and be able to get all sorts of different restorative materials and preventive materials into dentists' hands so that they can play with it. We're very tactile people.
We are very tactile
So
people.
it's a great opportunity.
So talk to me, okay, full disclosure, was not familiar with Centrix until I was given the opportunity to have a conversation with them recently. So, and when I said that, they were like, yeah, we hear that a lot.
We do.
So just give me a little, pitch on Centrix, who they are, because their story is really pretty amazing.
It is.
And I think people should know about them.
Absolutely. So Dr. William Dragon actually started Centrix way back in the 70s. And he was a practicing dentist that really saw a need for making dentistry easier. And his focus was on delivery systems first, because let's face it, we're working with a very small environment. It's dark, it's wet. We need to have very precise instruments and restorative materials. And so he started with the Benda brushes, micro applicators, snap fit guns. So really and truly, if you're in a dental office, we've been in your office. You just might not know our name.
That's fair.
We're a very small company. We're based in Connecticut, and it's really a family-based company. Unfortunately, Dr. Dragon did pass on, but his son is actually carrying the torch. And so we're still able to really carry on his name and carry on all of his ideas about how to make dentistry easier.
There are so many great companies out there that have similar origin stories.
Yes.
Dad was a dentist or, whatever. And I think dentists and clinicians in general love to work with companies that know dentistry.
Absolutely.
And that they're family owned, because dentistry is such a cottage industry. It's such a community-based industry.
Oh, absolutely.
So why wouldn't you partner with companies that are sort of living your truth?
Exactly. And my sales team is primarily based of clinicians.
Yep.
So most of us are hygienists. There's a really good amount of dental assistants. So they're all able to actually work with the products and the competitors so that we can really speak truth to the products.
That's awesome. All right, so let's talk prevention, because that's your world.
Yes.
All right, what's hot, what's not? What are we seeing on the prevention side?
All right, so here's what I will tell you. In the 30 years of being in dentistry, I haven't seen much in the way of change in prevention until about the last decade or so. And this is where things get really exciting, because oftentimes as hygienists, we've been talking about brushing, flossing, rinsing with mouthwashes, right? But now we really do have a focus on prevention and different phases of prevention. So, if I can just kind of put on my hygiene hat for a second.
Go.
Okay. So as a hygienist, we have always been taught primary prevention, right? Prevent disease from happening. How do we do that? Well, we are going to use professionally applied fluoride varnishes, right? We are also going to instruct patients on proper home care. And we're going to do nutritional counseling and behavior modifications. Anything that we can do to prevent disease from happening. That's through primary prevention. But if you can break prevention into 3 phases, you also have to take into consideration secondary prevention. And here is where we start to see the signs of disease happening. You might see some white spot lesions. You might actually find that a patient has had a change in their medical history that might be causing dry mouth. So we need to step in and really and truly get rid of the watch and wait approach. So now we're stepping in and using the tools that we have at our fingertips to, again, really halt whatever is happening so that we can preserve dental tissue. And here, again, what are we going to use? We're going to use professionally applied fluoride varnishes. We might start to use SDF, a silver diamine fluoride. You can also be using peptide scaffolding products that will help to remineralize enamel. And of course, we're still going to be talking about behavior modifications. Now, if those two things don't work, we might find ourselves in tertiary prevention. And this is where, as a hygienist, we actually look in the mouth and we see disease happening.
Right.
It's active, it's in our face, and now we have to really and truly employ some different tools that we have in our tool belt to stop the progression of the disease. And this is where it gets really interesting. And this is where you, as a doctor, are going to step in. So what we're doing is we're identifying disease. We are then going to go ahead and possibly treat it with silver diamine fluoride. Obviously, our professionally applied fluoride varnishes. And then you, as a dentist, you need to do something to restore the cavitated lesions. So you can now step in and use a fluoride-releasing glass ionomer restoration, right? So now we're really taking the approach of more of a medical management of dentistry rather than the surgical management of dentistry. And that's really exciting.
Yeah, and don't you think patients prefer that? I mean,
They do.
Patients watch the podcast. We get actually a fair number of consumers that watch the podcast, and I think overarching is they don't want to be in our chair. They don't. They want to come see you. They don't want to see me. They want to see you. They want to talk about your recent vacation. They want to talk to you about their dog, get their teeth cleaned up, get a good bill of health, and walk out the door.
Exactly. And that's where it does become really fun for a hygienist. Prevention can be fun. It can be a revenue builder for the practice too. We can't forget that. But the reality is that a healthy patient is going to refer other patients to us, right? They're not going to dread coming to see us.
Right.
There are a lot of patients out there that really don't want to come in. They will cancel appointments, fail appointments. Maybe they have to take a medication to relax so that they can come in and actually go through any kind of restorative care. We really want to mitigate that and really practice more of a minimally invasive dentistry approach.
Can we talk about some of the myths of SDF and like best practices? Because I still think a lot of doctors, the old black stain concern, and I think that has probably kept many from adopting it. So best types of cases that we could be using SDF on, maybe how Centric's product is a little bit different than some of the others on the market?
Absolutely. So SDF has been around for a long time.
Yeah.
Okay. It was first cleared by the FDA as a desensitizer. So we know now.
Can we just laugh about that?
So here's the thing. If you're using it as a desensitizer and there's no active caries and there's no demineralization, you're not going to get that black staining. Okay? What it's going to do is if there is metabolically active bacteria, that is going to stain dark. And it's only that infected dentin.
Okay.
It's not the healthy tooth structure. So that is a huge myth when we're talking about SDF, and it really does keep general dentists from using it in practice. But the reality is that 1 in 5 adults are walking around with untreated decay. A lot of them are untreated because they have been traumatized or they're nervous. They don't have the finances. SDF really does give us that interim step in restorative. It gives our patients more treatment options, and it does help to halt the disease, stop the progression, so that maybe we are buying our patients a little bit more time before they can come into the restorative appointment.
All right, so we've talked about prevention, a little SDF, but let's talk about fluoride. It's a hot topic.
It is.
Everybody's talking. People who know nothing about fluoride are talking about fluoride, so this is a hot topic. Let's talk about, what are we seeing? I mean, are you guys getting feedback from clinicians saying they're having a harder time getting acceptance rates to be the same as it was before with fluoride?
Absolutely, absolutely, because here's what is happening. we are trying to educate the practices on why really almost everybody needs a professionally applied fluoride varnish in one way, shape, or another. Of course, the frequency intervals are going to be different depending on the patient's risk level. But because of all of the noise that's happening in the media, there is a lot of hesitation from the patient. And then, of course, the hygienist gets a little hesitant, and then the doctor gets hesitant, and it's really a snowball effect. So what we have to do is just take a step back, kind of put on our chemistry hats like we had in school, and think about how topical fluoride varnish works. We're not talking about systemic, we're talking about topical. So when you do apply a fluoride varnish to a tooth, a lot of things start to happen, and the biochemistry of the enamel is very complex. So if you can kind of bear with me for just a second, because it's nerdy, and I apologize, but there's a lot of science. There's a lot of things happening that we don't, as a patient, understand. Right. And as hygienists, we need to be able to describe this to them.
Perfect.
So you apply a fluoride varnish to a patient's teeth, and basically what happens is fluoride is now starting to dissolve into saliva, releasing fluoride ions, and then it's drawing out the calcium and the phosphate ions. This happens very quickly, and what happens is you're starting to build a calcium fluoride layer. Again, very quick transition that this is happening in. And what's really important to remember is that this calcium fluoride is a layer. Kind of think of the fluoride sitting on the surface of the enamel. It hasn't integrated just yet, okay? That integration takes time. Our end goal in applying a fluoride varnish is we want to have a fluorapatite layer created, developed, right, in the mouth. This is because fluorapatite is going to be more resistant to bacteria and acid attacks. So that takes time. It takes hours, even days for that to happen. So when we're talking about fluoride varnishes, there's a lot of different brands on the market. A lot of them have different carriers, but a rosin-based, like our Fluoridose fluoride varnish, what it's going to do is it's going to actually adhere to the enamel, okay? So think of it this way. If we can have the adherence, if we can have that close contact of the fluoride to the enamel, you now have the loosely bound calcium fluoride fully integrating into the tooth, and now over time, you are going to have it really and truly start to develop that fluorapatite layer.
All right, so what's the, how long is it efficacious for? If I put a fluoride varnish on today, how long can I expect for that to last?
Yeah, so that is a really tricky question, and I get that a lot because every patient is different, right? If you're using a product for, let's say, desensitizing, fluoride varnish is a desensitizer too, we can't forget that. It's going to be based on the patient's pain tolerance, and also their diet. If they have a highly acidic diet or high carbohydrate diet, they are probably going to have less of a lasting effect versus someone who does not have a low acid diet, low bacteria load, that type of thing. So it's a very tricky question to be able to answer, but the ADA and the AAPD has set forth some guidelines for us. So if we can do a risk assessment on each and every patient that comes into our chair, we can identify whether they're low, moderate, or high risk. Low moderate patient, or I should say a low risk patient, they should be having a professionally applied fluoride varnish every 6 months. Once you start talking about someone who is moderate to high, they should be having a professionally applied fluoride varnish every 3 to 4 months. And that's set forth by our governing father, the ADA. Yeah. And studies show that those have long-term, lasting, really great effects for that patient.
So systemic absorption, what are the studies saying for topical application versus other sources?
So here's what is going to need to happen. We want that adherence of the fluoride varnish onto the enamel.
Which means you want it to feel sticky.
You do.
Even though patients in our pediatric cologne population doesn't always like it. But clinicians need to be reassured that stickiness, that is valuable.
Right.
There's value in that.
Exactly. Now, have you ever read Emperor's New Clothes?
Oh, yeah.
Okay. So you know the idea of, okay, you're told something's there, but you can't see it, you can't feel it, and you're just supposed to trust the product or the process, right? Well, having something that you can't necessarily feel in the teeth is kind of the same idea, don't you think?
Yeah.
So oftentimes what I will do in my lunch and learns is I will have hygienists and the team apply fluoride varnish to themselves, and then I'll ask them 10, 15 minutes, half an hour later, hey, do you still feel that on your teeth? Oh, you do? Great. That's what we want. That is the medicine working.
Yeah.
Right? We really do want it to become tightly bound to the enamel. And again, that takes time. And I understand a patient's concern. So what I will tell you is that there are some varnishes that are going to be more gritty, more clumpy. And, you know, Fluoridose, it's a really great product. It's one of the reasons why I was tied into Centrix, because you just have to go ahead and put a very thin layer on the teeth. It goes on clear, it dries clear, and it gives you more of a matte finish. You don't have to worry about your lips sticking to your teeth.
Yeah.
Right?
I think it's empowering for clinicians to know that stickiness, they don't have to make an excuse for it.
Right.
That it has a proper value for them.
Exactly.
And honestly, for patient populations that are very concerned about fluoride intake,
right,
the stickier it is, I would imagine the more it's staying where you've applied it and less of that is being ingested, which has to have value, right?
Exactly. If you can't feel it and you can't see it, where did it go?
I don't know.
Right?
I have no idea.
Exactly. And I'm sure that time will tell us.
Sure.
And studies will tell us. But right now, I, as a clinician, have to say, like, if I can't feel it, if I can't see it, if I can't taste it, so to speak, then where did it go? What happened to it?
Well, one of my soapboxes is that I'm so annoyed with pediatricians getting in the fluoride game because they don't do the risk assessments. Yes. They aren't talking biofilm. They're not even removing biofilm.
Right.
It's just, and dose issues, if parents are genuinely worried about fluoride varnish applications and how often, I have no idea. As a practicing dentist and as a licensed hygienist, when they come in, how well are we really documenting their exposure? If they've had treatments at their pediatrician, they're getting treatments at your office. I mean, that's a genuine concern that I have. We're not working collaboratively as a medical team.
Exactly.
And we're doing things along with, you hit it perfectly. Risk assessment.
Right.
Biomechanical debridement. Like we're doing all the things to go along with the application.
Exactly.
Because that's what the science tells us we need to be doing.
Right. And here's the thing. We all have bacteria in our mouth.
Of course.
Right. We're not going to eradicate it because some of that bacteria is good and some of it's not good. All of our diets are very different. Our medications are different. I mean, there are over 500 medications on the market that are causing xerostomia, and those patients that have that medication, they can definitely benefit from that fluorapatite, from the fluoride varnish, right? So we are doing a disservice if we're not doing those risk assessments. Dentistry is not a one-size-fits-all.
Sure isn't.
So,
all right, what else is hot? What else do we need to dive into?
All right. Oh my gosh.
I know.
You know, I will say, I would actually like your take because you are a practicing dentist. Here's the thing. Are you using STF in practice?
I do.
You do?
I do.
So can I ask you, when you use it, how are you using it?
For me, it's mostly geriatric populations. Like I've got a really interesting case of a patient and there's just root decay everywhere. And she's in her 90s now and we've all collectively decided that SDF is our treatment choice, along with glass ionomers where we can get access to them. But a lot of them are I can't physically get to with like an instrument or whatever.
Exactly.
So it's been great for her.
Yeah.
I can at least do an application every 3 months and just try to keep it from progressing and try to keep her as healthy as I can. I actually use it for pediatrics as well. I'll place a little spacer in between the two primary teeth and have them come back the next day so we can actually direct apply it to the incipient lesions. So now that's kind of a time suck and I know people are like, oh my gosh, you do that, but patients are incredibly receptive to it. We'll pop the spacers in and we'll say, all right, just come back tomorrow in 5 minutes. We'll be done.
Awesome.
Yeah.
Great. And it's great that you have time for it in your schedule too. Not everybody does.
I know.
So there are really great tricks that you can do to get it into proximal. So if you have super floss, I guess this is a plug for super floss.
There you go. To all of our super floss fans out there.
So if you have super floss in your office, all you have to do is thread it through the teeth, until you get to that kind of fibrous, thicker part. Take your micro applicator, dip it into just, like I said, 1 drop of SilverSense SDF. Get that micro applicator nice and wet. Then touch the micro applicator to that fibrous part of the superfloss that is interproximal and watch it travel. then all you have to do is kind of like
What
seesaw
a
it back
great
and forth.
idea.
It is such a time saver,
Yeah.
and your hygienist can do it as well if you can't, right? So because you're a very busy doctor,
Yeah.
right?
It's not, again, it's not the it's use of my time.
Exactly.
But we're passionate about arresting those for our pediatric patient population, and they're the most receptive to the SDF.
Oh,
frankly.
absolutely. And so let me ask you, are you applying a fluoride varnish after you do the SDF?
Yes, we are. Actually.
Excellent.
Yeah.
Oh, great. Because here's the thing. If we're using SDF as a caries arresting medicament, we really do need to place a fluoride varnish because we know that that patient's high risk.
Right.
And we know that that bacteria is not just touching, let's say, the mesial of 12.
Right.
It's also touching the distal of 13. So what we need to do is we need to protect all the surfaces of the teeth from that bacteria.
Those are great tips. I can't wait to put this out to the masses because people should be using it for pediatrics for sure. Anyway, those are not patient populations that are easy to treat. And if we can stop them early, that the 3-year-old that comes in and I can just do that really fast. And parents like that so much better.
They do, because everybody's busy.
That's right.
And
they don't want me cutting on their kid. Like, they don't want me to get them numb. They don't want to sedate them. They don't want to go through all that.
The fact of the matter is, what we want to do is we want to preserve natural tooth structure. We want to prevent premature tooth loss, and we want to halt recurrence of disease.
That's right.
And that's what the SDF and the fluoride varnish allows us to do.
All right, Sarah, we had so much fun yesterday that I had to get you back in here because I'm going to be honest, I've been walking the floor. And I still feel like SDF's getting this rap. Like, people aren't using it. They don't. They're not embracing it, putting it in their practice. I've gone to a lot of booths, talked to a lot of people since we've been here. So I went and grabbed you. I was like, we got to set the record straight. Let's talk SDF one more time.
Okay.
Put it out there. How do we get people to buy in?
You're 100% correct. And I've actually been having this very conversation this morning alone. Everyone comes up to me and says, but it turns the whole tooth black. And I have to walk them back and say, okay, let's just for a second imagine that you're back in dental school and you have a patient in front of you and you're presented with 2 options. Option 1, you can treat the carious lesion with 1 drop of a 38% silver diamine fluoride, like Silver Sense. All you need is a Dappen dish, a Benda microbrush, and that 1 drop. You literally just take that micro, dip it into the liquid, scrub it into the lesion, let it air dry for 1 minute. There is no injection, there's no drilling, and you can then restore it to beautiful. This is going to buy the patient time and it's less traumatizing. Or you can have option 2. Here is where you're handed a handpiece that's going to be rotating at 400,000 RPMs. It's loud. It is spraying aerosols all over the place.
The source of all dental trauma.
Exactly. And we know, have you ever seen the video, Saliva is Red?
Oh, yeah. Oh, my gosh.
So just imagine that you are in this room and there's just a cloud of dust and debris and bacteria all filling the room. You also have to inject the patient with a needle, which can be traumatizing. Now you've got the loudness, you've got the claustrophobia, you have the needle. This can be very traumatizing to the patient. You are also cutting into infected dentin and sometimes healthy dentin because you're trying to restore the tooth, right? Here's the problem. We are traumatizing our patients when we have another option. So when we put it in that sense, just put yourself in that patient's shoes. Would you rather have option 1, less traumatizing for both the patient and the clinician, or option 2? What would you choose?
Well, I know what I would choose. Option 1 for sure.
Right.
And especially because we talked a lot yesterday about the fact that really in different applications of SDF, you're going to get more staining or actually less staining depending on what the disease process is. And you can go back. Once you've hardened that tooth structure, you can restore it back to pretty.
Absolutely. You can use a fluoride releasing glass ionomer. You can restore with composite. You can do a crown and a bridge over it.
Yeah.
Right? You absolutely can restore it back to beautiful and back to health and function. So this really, truly is a product that is a miracle worker that is just an interim step in your restorative process.
Is anybody out there using it right now for indirect pulp caps and that type of like interim restoration work when they're inside a tooth and they want to try to stop or slow down the progression because they don't want a root canal.
Right. So what some practices are doing, and this is what they're telling me,
Yeah, sure.
is that they say, hey, listen, I'm going in and I'm starting to drill out all of the infected dentin, and the decay goes deeper than I thought. And I know I'm about to encroach in the pulp. So I will literally stop what I'm doing. I will purposely leave decay behind,
Yeah.
and then I will go ahead and put a dab of Silver Sense SDF in there. I will allow that decay to harden. It becomes glass-like, right? Now you can go ahead and you can restore right over that. So it does actually take away the possibility of having to go right into the pulp.
Yeah. How long should they let it sit before you get that glassy, like, do they need to send the patient home and bring them back? Or are they taking them to final restoration the same day?
Every practice is different and every patient is different. There are some practices that are using SDF because they do not plan to restore a tooth, right? Think of, let's say, your pediatric patient who has a deciduous tooth, it's going to exfoliate and it's not going to be beneficial to put that child through trauma. They're literally just going to apply SDF and then continue to reapply it, let's say, every 6 months. Yeah. But then you have your other patients, your general practice patients, who are possibly not able to stay today for the restoration. We're using SDF, we're stopping that progression of the disease, and we're having them back. There are some dentists, though, that are actually using SDF and restoring same day. And so what happens is when you do apply the SDF to the lesion, you will start to see that it is starting to become dark and hard and glassy almost immediately.
Okay.
There are some dentists that will actually light cure it on the day of application. Now, the reason for them wanting to do that is because they want to restore same day, and they want to make sure that they can mask that darkness with a beautiful restoration.
Right.
So if they light cure it, they now have the full picture of exactly what color they're working with.
Yep.
Okay?
Yep.
So I hope that answers your question.
You can also clean it off the walls. I can speak from experience.
What
on
do you
that one.
use?
So, Reba. So when the light hits it, I did actually use Elevate as well for a long time. And it's kind of the same thing. The minute they photo activate, you're like, oh, okay, well, there's the SDF. I can find it perfectly now.
Exactly.
And then, you can clean things up and restore, which is really nice. But maybe that's an excellent point about the flowability of your SDF staying exactly where you put it.
What's really nice about our bottle, we've designed it so that you have a precise drop.
Yep.
And that's one of the things that a lot of practices have said to me is that they love the dispensing bottle, that when they need one drop, they truly get it.
Yep.
So
that's so awesome. Okay, well, thank you for dispelling all the rumors out there. I really hope now we're champions of SDF and that more people will see it as a real workhorse in their practice.
Absolutely.
And that's just part of their normal armamentarium.
Definitely, because I will tell you in my 30 years of being in dentistry, there are way too many patients that are walking around that are too afraid to come into our office.
Right.
And we need to get them in so that we can take care of their mouth. We know that that's the gateway to their overall health.
Absolutely. Thank you so much.
Thank
Enjoy the rest of the show.
Yes, you too. Thank you.
You're like my eye on the sky now. I can just bring you in and talk about anything we want.
Exactly.
All right. Bye, guys.
All right.